Hello, my name is Dr. Eric Herbranson. This lecture is about engineering the endodontic access prep for dentin conservation. This is an idea that has been developing for about the last 10 years, and it's involved some epiphanies by a couple of different people. I'd like to go over a little bit of the history of the development of these ideas. The first person that really should be mentioned is Dr. David Clark. He's a generalist from Tacoma, Washington. And he was looking through his drawers in his lab one day and came across this pile of teeth. And he asked himself the question, why was this pile so big and what caused all of these failures? Why were they in this graveyard drawer? He called in Dr. John Cottam, who's an endodontist from Durango, Colorado, and hooked up with him, and they started discussing these issues. One of the situations that David would run across was that he'd find a tooth like this, refer it out for an endodontic procedure, and get back the result on the right. And the tooth has basically been destroyed with an excessively large access prep. And the epiphany that he had was that the endodontists were only looking at the roots, the restorative dentist was only looking at the crown, and nobody was looking at the middle of the tooth. And he felt that this was an area that we had to take ownership of. He named it the pericervical area, and his epiphany was that all of us need to own this area, all of us need to treat it, and that the problems that are created here are engineering problems that can be solved with engineering solutions. Ultimately, he and Cottam, with some input by myself, ended up developing a number of articles about this. The one where it is codified in this issue of Dental Clinics of North America, the Modern Endodontic Access and Directed Dental Conservation. My personal epiphany was a case that I got about 10 years ago from an endodontist in Europe. She had a tooth that had fractured root in it, sent it to me for a micro CT scan because she wanted to see what the root canal filling looked like. And I looked at this tooth, and before we go to the results of that look, I'd like to ask you question. I want you to form in your mind what you think the cross-sectional area is of the red line in the lower right picture. These are your choices. Many people think that it's A or B, and we're going to find out in a moment what it actually is. If you take the axial view of this tooth, this is the axial view of the tooth. We'll take one trip down through the axial view, then we'll come back and go through it again in stop motion so you can see the features of it. So let's play it again. This is the coronal part of the tooth, and you can see the dentin, the enamel, the pulp chamber, and the two posts that were put in the distal canal. We're going to go down a little bit further, and now we're down to where this separates into two canal systems at the bottom of the pulp chamber. We'll go a little bit further, and now we're at the area right before we get to the furcation. And you can see that this tooth had 3 canals in it, in the mesial root, which occurs about 17-18% of the time. These were all 3 filled, all 3 clean and shaped. And let's go a little bit further. Just as it goes into that furcation, you see that it goes from 1 tooth to 2 roots, and look at the size of the concavity on the mesial root. This is far more typical than people think. We'll go down a little bit further. And this area here, you can see we're probably a third of the way down the root. We still have a huge concavity, but also notice how the center line of the files are significantly transported toward the furcation. And the reality is there's a strip perforation on this tooth. So this was my epiphany and my contribution to this. Another case, similar. This is interesting because we had the same result. The files were transported toward the furcation. There's, for all practical purposes, a strip perforation on this tooth. But interestingly enough, there's still bone over that area. So this was acceptable to the body. My question is, how long would this tooth go without having a fracture? If you look at cross-sectional areas of CAT scans of teeth, you'll see that virtually all lower molars have huge concavities on the furcation side of the mesial root. The distals also do, and this is a fairly ubiquitous anatomical finding in lower molars. In fact, concavities are everywhere on our teeth, and they reduce the amount of available dentin structurally for what we need to do with them. So the principle here is there's less dentin than most people realize, and that this lack of dentin impacts our access design decisions, our instrument decisions, and our post decisions. And one of the reasons we get confused about this is if you actually just pick up a tooth and look at it, or you take a radiograph of it, you see that the cross-sectional profile of this tooth has got a fair amount of taper to the root, a fair amount of taper to the canal system, and both of those look fairly robust. But if you actually sit down and really look at the cross-sectional area, what you're looking at here is a summation of the total width of the root, which in any given part may not be what the root actually is. If you look at what the root actually is, these roots are significantly thinner. They're more parallel, especially in the coronal part of the root, and there's significantly less dentin than you think here. The problem is our mental model of this is what creates the decisions we make around treating these teeth. So that mental model drives our decisions. The reality is there's less dentin, there's less taper, and there's substantially more concavities. So if you're going to be sophisticated about this, you need to become a student of the anatomy of teeth and understand where those are. And this is a pitch for the 3D Tooth Atlas, which has got 600 teeth in it that are high-resolution CT scans that are formatted in such a way you can take them apart, make them transparent, rotate them around, and this is a product that I helped develop starting back in the 1990s, late 1990s. It's a valuable resource for understanding dental anatomy. So the proposition of this lecture is the following. 1, dentin is the strength of the tooth. 2, the more dentin you've got, the more fracture resistance you have. 3, dentin cannot be replaced. You cannot fix it with restorative materials. And because of that, you have to conserve the key dentin, and that conservation must be designed into your endodontic and your restorative procedures. So key dentin is the issue here, and the key dentin occurs in the pericervical area. There's basically 2 areas we need to work with. The first is the pulp chamber area, and the second is the upper canal area, because these are the areas that traditionally are abused by our procedures. Give you an example. This is the silver point conundrum, and this feeds into John Cotomy's epiphany in all of this work. And he looked at cases like this and said, on the right we have an old, maybe a 30-year-old silver point filling that seems to be working, although according to our disease model it shouldn't be working. Why is that? On the left we have a gutta percha filling, good cleaning and shaping, plenty of room for irrigants, and in fact it's failing. So these teeth are not following what our expectations from our disease model are. Cotomy asks this question, why? And if you look at the typical education material, you'll start to understand what's going on here. All of these were taken off of the web. They come from various sources. They're all designed to be educational material. The one I like the best is the one in the middle and the upper, and he labels one of those accesses incorrect, the other one correct. The reality is he's got it completely backwards. The incorrect one is the one that conserves the dentin and the one that maximizes the strength of the tooth. And it looks more typical to what we're designing today. This leads us into John Cotomy's 3-strike rule, which is a baseball metaphor. We're trying to get a handle on what your long-term prognosis is when you evaluate a tooth. First strike is you have excess removal of dentin in the access. Another example of a relatively current illustration from a manufacturer, article from 10 years ago. You'll notice the access pre-op and the post-op In my mind, this is grossly over-accessed, and there's a substantial amount of dentin that was removed here that in fact didn't need to be removed. You get into the restorative, and with all of the porcelain protocols that are available now, some are requiring relatively substantial amounts of reduction to make room for the porcelain. And if you follow this particular example, almost 75% of the coronal volume is gone. If you do a endodontic procedure through that crown, open up the inside of the tooth, you are left with very little dentin to support this crown. Now, the newer porcelains don't require this, but to give you an example of what's going on, this is a case I treated a few months ago. It's a 2-year-old CEREC crown, and when I do the endodontic procedure on this, cut a hole in the crown, do my access prep, we've got almost nothing left to support that tooth, and we're looking at a potential snap-off failure of this. So this leads us to Cotomy's second strike, which is excess axillary reduction, and this is a restorative issue and a restorative responsibility. The third strike has to do with the endodontic preparations, and most endodontic preparations are relatively too big. And to give you an example, these are all teeth that have relatively biggish access preps in them, relatively biggish cleanings of the canal systems, and they have cracked roots. We think this is a substantial problem. Correcting this is at the heart of the new protocols we're going to discuss. So this leads us to Cotomy's third strike, which is excess coronal enlargement of the canal system. So Cotomy's answer to the why that Clark brought up is that what this is about dentin, and the more dentin you've got, the better off you are, and the stronger the tooth, the less you're fracture resistant. So now let's look at the upper part of the canal, the coronal part. But to do that, we have to go back and talk about file design for a moment, and how that fits into tooth anatomy. The early NiTi files were straight taper instruments. They had a variety of tapers, 0.02, 0.04, 0.06, and they came in tip diameters from 15 to an 80. And if you actually look at what the dimensions are at various parts in the file, you'll see that on these size 20 instruments, they're dramatically different at the D16, or the upper part of the flutes. And the O2 is a fairly small instrument at 0.5 millimeters, whereas the 0.06 is almost 1.2 millimeters in diameter at D16. So there's quite a bit of variation in the diameter of files up high as the tapers change. They came to the realization that they needed to vary the taper of these instruments to give themselves adequate taper for control of the gutta percha and to give themselves room for irrigation. And so they came up with pro taper instruments. They have two types. There is a shaping instrument, which has got a convex pattern to it, and there is a finishing instrument that has a concave pattern to it. Now, the thought behind this is actually a good one. You got deeper shape at the apex, gives you room for irrigation. You have a fairly steep taper at the apex, which gives you control of the gutta percha during condensation. The problem comes in the upper part of the canal was specced out at a diameter that's unrealistically big for the teeth that they're being worked on. These are 1.2 millimeters in diameter, and all the new variations off of this instrument are also 1.2 millimeter in diameter. Even at D10, they're over 1 millimeter in diameter. So we ask ourselves, are these files too big up high? I would say yes. And does that create a stiffness, which is a problem? I would also say yes to that. This is the product shot that's used to show how flexible the instrument is, but you'll notice there's no flexibility in the upper part of the instrument. And it's important to realize that the stiffness of an instrument varies with the square of the diameter. Otherwise, if you double the diameter of the instrument is 4 times stiffer. So bigger diameters get stiff very quickly. This led to the evolution of a new family of variable taper instruments, the SSWhite V-tapers, And the difference is these V-taper instruments have smaller high diameters to them. And if you look at the D12 diameters in size 20, they're almost 0.4 of a millimeter smaller. The 25 instrument is 0.3 of a millimeter smaller at D12. And this is significant when you look at the width of the roots that you've got to work on. This is a purposeful design, and what this design does is respects the dentin in the root structure that's there. Why is this important? An article in Quintessence in 2008 identified a highly conservative approach as being important for both endodontic and restorative procedures. My friend Charlie Goodacre did a chapter in a book on the income of outcome data on diagnosis and treatment planning. This is basically a chapter on fracture resistance, but if we look at one part of it, which is post diameters, he has some recommendations on post diameters, and Charlie is a very highly skilled dental anatomist, so he understands this very well. And these recommendations are based on the average dimensions of the teeth in the literature, and they're based on the recommendation that you can only use 1/3 the root diameter. Anything more than that is going to weaken the tooth significantly. Many people think that that should be 1/4. And his recommendations are the biggest post you can use in a mandibular incisor is 0.6 millimeters. It's hard to find one that small. Most teeth, it's 0.9 millimeters. And cuspids are 1 millimeter, and the maxillary centrals are the biggest at 1.1 millimeters. You would think that cuspids being a bigger tooth than a central would allow for a bigger post space, but the reason is even upper cuspids have concavities, subtle concavities in the mesial and distal, which actually reduces the effective diameter and the effective amount of dentin in those teeth. Some teeth require cast posts. They can't use regular round posts, and these are teeth that have a more blade shape to them, like mandibular incisors and maxillary premolars and the distal roots of mandibular molars. So if we replace post diameter with file diameter, and we bring back up this chart where we looked at the upper diameters of the file systems, you can see that at 0.9 is the maximum we can use. We can't use these instruments in most teeth because they're too big around. And this is the reason that we have the SSWhite V-tapers. So the first problem of large diameter files are large diameter multi-taper files is that they're too big for most roots. To give you an example and a comparison here, this is what a Pro Taper F2 25 tip looks like, and what I've done is exaggerated the width of the instrument so you can see what the actual profile is. I've done the same thing with a 25 V-taper. These are both 25 at the tip, and I've overlapped those so you can see how that comparison is. You'll notice that the apical part is essentially the same shape. You have a few millimeters of 0.6 taper, which is a good for trapping the gutta percha when you're doing condensation. Above that, you have a few more millimeters of fairly robust canal space for irrigation. You get into the upper part of the canal, and this is where the problems start. You'll notice that the Pro Taper is substantially wider than the V-taper, and it's wide at a place where it's taking away too much dentin. If you look at straight taper instruments the same way, this is an overlap of a V2006 with a 2004 straight taper instrument. The problem here is the upper diameter is okay, but it's much smaller at the apical part. You don't really have enough taper for gutta percha control or room for irrigation. If you go for a bigger taper down below, you get a more robust shape for gutta percha control, but you get excessively high width on the upper part of the canal with the straight taper instrument. So this illustrates the need for a multi-tapered instrument that's more tapered at the apex, less tapered at the upper part of the canal. Now, how much dentin do you really have to work with? So what I did was a little study. I was curious about how much dentin there was on the MB2 of upper first molars, because this is one of the thinnest roots we work on. And I thought originally I was going to have to do a literature review on this, and then it dawned on me I could use my clinical cone beam CT data that we had from our patients. So I started a study on these. And what I did was pick teeth that had an obvious MB2 with them, looked at the width of the root just below the furcation. So this is as high as the root where it was an individual root was. And I looked at the MB1 location width, and I got a range there of around 3.2 millimeters in diameter in width. I looked at the MB2, and I got a range there of 2.3 millimeters. The lengths actually varied substantially more than the widths did, and they went anywhere from 5.5 millimeters up to 11.5 millimeters. And this is the length of the root from this measurement to the apex. The actual root where it went into the pulp chamber was quite a bit longer than this. This is just the root part of the thing. Now, if you look at what the ramifications of this are for file selection or post selection, and you have a quarter to a third of the root you can work with, on the MB you can have a canal system that's something in the 0.75 to 1 millimeter range on an average tooth. On the MB2 it's like a 0.5 millimeter to 0.7 millimeters. These are not very big spaces. And if you're going to err on the sides of being a little conservative because you don't know for sure what your root is, you're looking at the bottom end of these. So if you look at the ProTaper system, the older multi-tapered instruments, you really can only use the first 4, 5, 6 millimeters of these instruments before you get to a diameter that is bigger than this, and the canals are longer than that. If we look at the V-taper system, which has a smaller upper diameter, you can see that on the 2006, its maximum diameter, even at D16, is only 0.6, which fits in nicely to an MB2. The MB1 could be handled with a V2508, or you could do a 2006 on it. So these instruments are designed specifically to respect the root form that they're being used in, and this is a safety feature that eliminates the excess amount of dentin conservation. So you can pretty much use these instruments in most molars, and you're going to be appropriately shaped or very close to it. Another problem with instruments, especially the big ones, is lateral transportation from stiffness. And all these instruments want to straighten out if you put them in a curved canal. And there are curved canals everywhere. Virtually all molars have curved canals when you're doing the endodontics on them. And this, again, the stiffness increases with the square diameter. So a bigger instrument not only takes away more dentin, but it's stiffer and has a much more of a tendency to straighten the canal out because of the lateral transportation. And this is an important consideration. It's one of the main reasons that these files tend to move the shaping toward the furcation side of the tooth. So the second problem with large diameter files is they transport canals. This is a study that I found very interesting. It's predominantly about what happens to debris when you clean and shape instruments. And it's not about anatomy. So these are your pre-ops in A, your post-cleaning in B and C. E is a pre-op cross-section in the middle part of the root. F is a post-op after cleaning cross-section in the middle part of the root. What I did here was I took the E and I put it on top of the F and recolored it, and you can see that the size of the canal space that results here is significantly bigger than what was naturally there, and more importantly, it's all transported toward the furcation side of the root. And this is very typical of big instruments. So, can I do any better? This is a post-op cone beam CT that I did in a case I treated a while back. I was trying to see if my transportation was better, and you can see from the 3 sequences here that I stayed pretty centered with my cleaning shaping on my MB root, but you'll also notice that I use a fairly small file system in the MB2 because I understand now we don't have a lot of dentin to work with there. And this is what it looks like in a more traditional 2D view. So our awareness of the problem, which comes from our study of dental anatomy, and using the right tools will alleviate these problems. This is my first V-taper case that I did a couple of years ago when these instruments first came on the market. I showed this at an endodontic meeting in the Bay Area, and I asked the question, were these file shapes too small? And 2 people raised their hand. One of them said yes, they were too small because you can't irrigate a space like this. The other one said yes, they are, because you can't obturate a case like this. I would say that the X-ray proves the point that you can obturate these, and the cleaning and shaping can be done by changing your protocols. So they were thinking about this from the standpoint of the instrumentation that they had on hand. And what it's important to understand is that the tools that you use, the armamentarium you use, should serve your concepts and techniques. They should not drive your concepts and techniques. And we've always taken the attitude, Cotomy, Clark, myself, and a number of other people, that if we don't have the instrumentation, we modify something we already have, or we get somebody to build it for us. And Clark and Cotomy actually ended up developing a whole line of access burrs that I'll talk about in a little bit. SSWhite has been very accommodating to these ideas and has helped us with access burrs and has helped us with the file systems. I like this quote from Nassim Taleb out of the book The Black Swan. He talks about ideas, and ideas are sticky. We treat them like possessions, and the problem with that is that because we treat them like possessions, we're not likely to change our minds when we are presented with new ideas and new interpretations. But I've always taken the point that any idea I've got, I'm willing to modify given enough data. And these concepts were certainly that, because they did in fact challenge my previous beliefs. So let's ask the question, how much dentin is enough? And we don't really have the complete answer to this, but I want to look at this in a sort of philosophical way. Teeth form by being universally laid down by the odontoblasts. And this is the upper first molar. It's only partially developed. So let's look at a cross-section of a tooth. This is one that's been around a while. It has primary dentin, and then it has secondary dentin. So if we make the assumption that the primary dentin is where the strength lies, that there is not really additional strength significantly in secondary or tertiary dentin, this is where we would probably like to have our maximum amount of prep done. And you notice that's not a round space, it's ovoid, and it's fairly narrow. This would be a biomimetic approach to the shaping of the tooth, i.e. it fits in with what nature has given us. And this particular tooth, that is 25% of the total width of the root in that direction. So this fits into the quarter of the dentin is what we have to work with. Another example where if we track where the canal probably was, the original canal was 18-20% of the width of the root as versus our endodontic preparation, which is done with a round instrument, which was a third of the shape of a third of the diameter of the root. So while this fits into the 1/4 to 1/3, we still got a cracked root. Maybe we have to think about the 1/3. This has led us to a new idea on access, and we're going to call this orifice-directed access. And this is a design to engineer the tooth for dentin conservation, and it's designed for each specific tooth. The principles are the following. The pericervical dentin is sacred. You want to maintain it as much as possible because you cannot replace it. If you take it away, the tooth gets weaker. That occurs in 2 places, the pulp chamber and the upper canal, and those are handled somewhat differently. The occlusal dentin is not as important because that dentin may be taken away for a crown prep. It may already be taken away and replaced with a crown, and you can remove that dentin with some impunity without actually structurally inhibiting the tooth. And we're going to use that strategy to make these preps easier to do. So in a conservative prep in a molar, you're going to go in, do your access prep, try to maintain the diameter of the pulp chamber, not widen it out. You're going to put a very slight flare into the canal systems. And to give yourself visibility into the canals, you're going to flare the occlusal opening so you have direct vision to the natural direction of the canal without having to change the canal at all. So this is what we would term an orifice-directed occlusal opening, keeping the pulp chamber the same space. You'll notice that if you do this, you end up with the pulp horns uncleaned. And we're going to call this the soffit, and I'll show you how to deal with that in a little bit. This prep ends up being what's called a calla lily. It comes up to the occlusal surface and kind of rolls over. And this prep is a balance between dentin conservation and access. And the opening of the occlusal part with the calla lily and the tapers gives you visual access to find the canals and make sure you do the job correctly. So old school, the instruments were stiff. They were a problem, stainless steel hand instruments, and they required a very straight line access to the canal system. They did not like curved roots very much. And so the thought was that we take away this triangle up high in the root to allow us straight line access to the root. Well, you take away a lot of tooth structure doing that. Many people still believe this, and this is based on Schilder's work from the 70s. In this particular protocol, the conservation of the dentin is sacrificed because of the instrument design. And it's important to understand that these were driven by the materials and instruments of the day. Today we have the new school version of this, which is keep that dentin. Don't worry about the curves because the new instruments can handle the curves, but to flare the occlusal opening so that you've got some visibility and access to the canal systems. So, if you're looking at these systems and their variations, this is typically what you'd get, projection off the canal system. You end up with that being the outline for your occlusal opening, and then you keep the pulp chamber as small as you can physically do it. But each tooth is a little bit different. So when you again have the soffit. So if you have a tooth that's got very wide divergent canals, you end up with a pretty good sized prep, which you may feel is excessive. And the solution to that is you can take a little bit of straightening of the canal system down at the root and change that a little bit. So there is room for modifying the upper part of the canal system slightly to compensate for removing too much coronal dentin. Another issue you get into is if it's narrow, you can end up with these crossing right at the occlusal surface, and the access prep would be very, very tiny in that area if you just followed the projection kind of protocol, and to the place where it's really difficult to work through. So I would recommend in that situation you flare that open a little bit more for visibility's sake. Now, I'll give you an example of how this can apply. This is a case that was done by Matthew Nealon, and the patient was referred 2 months after a brand new crown that the restorative dentist had done all kinds of staining in the grooves and characterization of the crown. The patient thought the crown was fabulous, was seriously bummed that this crown had to be gone through. Nealon presented some of these cases at a study club, and the guy came up to him and said, "Look, can you possibly do this through a little tiny hole?" And he says, "Yeah, I think I can." And you'll see the results in the bottom two x-rays, he had a 5-canal tooth, 3 mesial canals, and a really beautiful result, conservative prep, and a really small hole through the occlusal surface. You don't need to do this, but it is possible to do this with skill and microscopes, etc. The other thing that people are doing today is what we call an opportunistic design. So if you have a tooth that, for instance, has a really big cavity in it, and they want to maintain as much existing dent as they can, they'll move the access more toward the decay, and you'll end up with an access that maybe looks like this. The whole thing has been tilted toward the decay area of the tooth, and this allows you to keep as much dentin as possible. So people are doing this with decay. And again, you got the soffit in there. Well, what do you do with the soffit? Well, there's a number of ways of cleaning it out. You can take burrs and get up in there. You can take ultrasonics and get up in there. You can take explorers and get up in there with some sodium hypochlorite on. You just have to kind of think this thing through and see what you've got to get that debrided up there. It's not that big of an issue once you've done it a few times. Clinical example of a tooth. This is our initial penetration of the pulp chamber. These are the projections of the canals, and you'll notice that the outline form of the occlusion is dictated by the projections of these different canal systems. And this is my result. It's got a relatively narrow pulp chamber and a flared occlusal opening dictated by the canal projections. Incisors, we've changed the protocols to a more straight one. And what we do is cut a guide notch right in the lingual part of the incisal edge. And if it's a natural tooth, this can be repaired with composites. It's basically just a little ding there to give us a guide to where we want to do our access. We do our access, find the canal system, and clean it out. And then we go in, widen that out slightly with a triangular shape, and then widen out the pulp horns so that we don't get a tooth that turns dark afterwards. So this is basically straight line, some involvement of the incisal edge, repair with modern composite materials. This is a case that was done by Robert Core in Colorado Springs, and you'll notice that the resulting shaping of this tooth mimics the actual natural diameter and shape of the tooth, but the access prep that was used to get into this tooth is smaller actually than some of the diameter of the tooth. And you can do quality endodontics, debridement, etc. through a smaller opening once you think through the issues and are used to it. Another example of an upper incisor, we're using these endoguide burrs now developed by Cottamy and Clark. They have a triangular cross section. They are used for initial access, and they give you a very good view of the inside of the dentin so you can locate the canal systems. You end up with a skinny lower anteriors, very skinny roots. You need to be very, very careful about how wide you clean these out. You almost can't be too skinny on these. The x-ray on the right is a good example of the amount of tooth structure that should be taken away. The reason for this is these roots are very narrow in their mesial distal width, but they have a wide crown and narrow root. The other tooth that has this kind of shape, morphology, is the upper premolars. They have a wide crown and a narrow root on them that's fairly wide buccal lingually. The crown can be twice the width of the crown. Patient I had leaving for 5 years on a sailing cruise the day after I did this root canal. I didn't have a chance to get a crown put on it, so I did my endo, put in some fiber posts, built up the tooth, and tried to get as good a margin as I could. And I'm hoping he comes back and I can get a recall on this. It'd be interesting to see if this survives. Upper first premolar, long skinny roots with long, fairly thin cleaning and shapings and thin posts. Now, some premolars, especially the seconds, have a very broad, flat, almost blade-like canal system to them. And these are one of the teeth that really should have a cast post in it. It's very difficult to do this with preformed posts, although some people will put 2 or 3 very small ones in there, and I really can't argue with that protocol. Case in a lower premolar, small thin diamonds, and the EG burrs used for access. You notice that the access prep is just to the lingual of the cusp tip. On lower premolars, the center line of the tooth actually goes through the cusp tip, both first and seconds. Well, now let's look at the tools that allow us to do this dentin conservation we've been talking about. We have SSWhite to thank for most of these. They've been very generous in their support for helping us develop these concepts. One of their best kits is this overall kit. Includes initial access, the fine diamonds, the endoguide burrs, hand instruments, V-tapers, and their V-clean instruments. They also have a kit that includes mainly endoguide burrs, and there's another kit that includes the fine diamonds. These are all developed by Clark Cotomy, and it's their preferred instruments for accessing small shapes. These are the endoguide burrs. You'll notice they're all cone shaped. They're a modification off of the fissurotomy idea, and they create a shape which is significantly smaller than the Gates burrs. And the cone shape of it allows it to be used in a way that you can see better when you're looking down in there, and it makes it much easier to find canals and calcified teeth. If you're picking for canals, you will find that you can see the canal on the wall of the prep. They're a good replacement for Gates Glidden burrs for creating a small funnel as you go into the canals. Let's take a look at the V-taper file system right now. There are a couple of features we need to talk about. First off, it's multi-tapered, reduces the upper file diameter and stiffness, and still gives you adequate shape for gutta-percha control and irrigation at the apex. You can see the profile of it, and this is the kind of profile that's respectful of the root anatomy and what we want in a file system. It has a very effective cutting edge. It's perpendicular to the canal wall. It's probably the most effective cutting shape on the market today, and it's supported by a fairly heavy amount of metal behind it, so it's a relatively tough edge. There is a relatively big core to the file, and that gives you significant strength. With the new materials, these are flexible, and smaller upper shape diameters make them more flexible in big canals. So it's a good balance between cutting efficiency and strength. The recommended RPMs for these is 150 to 200 RPMs. This is slower than most file systems are used at. And the reason we recommend that is they're so efficient in their cutting that if you use them at a higher RPM, they feel they're a little too quick in their cutting, and they feel a little bit grabby and hard to control. So we slow the RPMs down. We take a 1 second cut, and then we clean them frequently, because the amount of space to load debris in is somewhat less because of the parabolic design of the edge. They're heat treated for flexibility and fatigue resistant. It's almost impossible to break one of these instruments with fatigue. These instruments are designed for safety. They create a more appropriate root form shape than any other filing system on the market. This helps you conserve the upper canal dentin, which is what this conservation idea is all about, and it minimizes or eliminates canal transportation. Let's look at the file system itself. You'll notice that they have tip diameters of 17 to a 50. The 17 is an 0.4 taper at the tip. Everything else is an 0.6 for the first 4 millimeters. Then it's an 0.3 taper, an 0.2 taper, and a 0 taper. So the last 8 millimeters of these files are almost parallel. and that gives you a smaller diameter up there, but still gives you adequate taper to control the gutta percha. There are 3 other instruments that fill out the product line. The first is a 2207. It is slightly bigger than the 2006, and it's the perfect instrument for biggish molars, mesials of lower molars, MBs, distal buccals of upper molars. There is a 2508, which is a more robust instrument with a steeper taper at the apex, and it's designed for distal canals of lower molars, palatals of upper molars, and lower premolars, that type of thing, where you need a bigger shape and a steeper taper at the apex. And then there's the 3008, which is a slightly bigger version of that. So between all of these instruments, you can usually find an instrument that will meet your objectives in your cleaning and shaping. Look at some cases from a core group of endodontists. An anterior case from John Cotomy. Notice how small the shapes are. These are very thin roots. This is an interesting case from Jeff Patford. It had 4 canals, which is highly, highly unusual in upper central. But you'll notice he was able to effectively treat these 4 canals through a relatively small access prep. So you can, in fact, treat complicated anatomy through smaller access preps. This is another case from Jeff where he was opportunistic in his access prep, tilted the prep toward the decay, and tried to maintain as much dentin as he could. Another case from Pushpak Nariana, who practices in Florida. Another case from Dale Jung. And this is spectacular for an amalgam. Exquisite craftsmanship. 90-degree curves, small accesses. This is an interesting case because you have to ask yourself, what file system are you going to use here? And it is an ideal case for the V-taper instruments where you've got a long, relatively parallel, small diameter upper profile to the file. Another case from Michael Trudeau, amalgam buildup with a composite close for aesthetics. Scott Weed, same situation, and amalgam core under a composite occlusal. This case to me is the poster child for these kinds of access preps, and it's got small upper diameters to the canals. They're big enough to get obturation, they're big enough to get irrigation, but they're respectful of the amount of dentin that's there. They don't transport the canals. They've got a small conservative opening of the pulp chamber, and it's got a flare in the occlusal for visibility and to allow for straight line access. So you get this kind of typical hourglass shape to the access. Does conservation make a difference? And I think it does. There's a recent article that was published by Christian, and he tried to answer the question, do these conservative shapes result in stronger teeth? And in fact, testing conservative shapes versus more typical access shapes and control of no shapes at all, the conservative shapes were almost as strong as the control cases with no access in them in the molars. Wasn't quite as clear in the anteriors, but in the molars they were stronger. So the conclusion is that conservation of the coronal dentin in fact does increase the resistance to fracture in molars and premolars. So to close, this is what I see the new look of endodontics being. And you have a case that is done with smaller instruments, conservation of the dentin, and some hand instruments were needed for the middle mesial. This is the new look of endodontics. And with that, we will take some questions. Well, now let's look at the tools that allow us to do this dentin conservation we've been talking about. We have SSWhite to thank for most of these. They've been very generous in their support for helping us develop these concepts. One of their best kits is this overall kit. Includes initial access, the fine diamonds, the endoguide burrs, hand instruments, V-tapers, and their V-clean instruments. They also have a kit that includes mainly endoguide burrs, and there's another kit that includes the fine diamonds. These are all developed by Clark Cotomy, and it's their preferred instruments for accessing small shapes. These are the endoguide burrs. You'll notice they're all cone shaped. They're a modification off of the fissurotomy idea, and they create a shape which is significantly smaller than the Gates burrs, and the cone shape of it allows it to be used in a way that you can see better when you're looking down in there, and it makes it much easier to find canals and calcified teeth. If you're picking for canals, you will find that you can see the canal on the wall of the prep. They're a good replacement for Gates Glidden burrs for creating a small funnel as you go into the canals. Let's take a look at the V-taper file system right now. There are a couple of features we need to talk about. First off, it's multi-tapered, reduces the upper file diameter and stiffness, and still gives you adequate shape for gutta-percha control and irrigation at the apex. You can see the profile of it, and this is the kind of profile that's respectful of the root anatomy and what we want in a file system. It has a very effective cutting edge. It's perpendicular to the canal wall. It's probably the most effective cutting shape on the market today, and it's supported by a fairly heavy amount of metal behind it, so it's a relatively tough edge. There is a relatively big core to the file, and that gives you significant strength. With the new materials, these are flexible, and smaller upper shape diameters make them more flexible in big canals. It's a good balance between cutting efficiency and strength. The recommended RPMs for these is 150 to 200 RPMs. This is slower than most file systems are used at, and the reason we recommend that is they're so efficient in their cutting that if you use them at a higher RPM, they're a little too quick in their cutting, and they feel a little bit grabby and hard to control. So we slow the RPMs down. We take a 1 second cut, and then we clean them frequently because the amount of space to load debris in is somewhat less because of the parabolic design of the edge. They're heat treated for flexibility and fatigue resistant. It's almost impossible to break one of these instruments with fatigue. These instruments are designed for safety. They create a more appropriate root form shape than any other filing system on the market. This helps you conserve the upper canal dentin, which is what this conservation idea is all about, and it minimizes or eliminates canal transportation. Let's look at the file system itself. You'll notice that the have tip diameters of 17 to a 50. The 17 is an 0.4 taper at the tip. Everything else is an 0.6 for the first 4 millimeters. Then it's an 0.3 taper, an 0.2 taper, and a 0 taper. So the last 8 millimeters of these files are almost parallel. And that gives you a smaller diameter up there, but still gives you adequate taper to control the gutta-percha. There are 3 other instruments that fill out the product line. The first is a 2207. It is slightly bigger than the 2006, and it's the perfect instrument for biggish molars, mesials of lower molars, MBs, distal buccals of upper molars. There is a 2508, which is a more robust instrument with a steeper taper at the apex, and it's designed for distal canals of lower molars, palatals of upper molars, and lower premolars, that type of thing, where you need a bigger shape and a steeper taper at the apex. And then there's the 3008, which is a slightly bigger version of that. So between all of these instruments, you can usually find an instrument that will meet your objectives in your cleaning and shaping. Look at some cases from a core group. It's an anterior case from John Cotomy. Notice how small the shapes are. These are very thin roots. This is an interesting case from Jeff Patford. It had 4 canals, which is highly, highly unusual in upper central. But you'll notice he was able to effectively treat these 4 canals through a relatively small access prep. So you can, in fact, treat complicated anatomy through smaller access preps. This is another case from Jeff where he was opportunistic in his access prep, tilted the prep toward the decay, and tried to maintain as much dentin as he could. Aesthetics. Another case from Pushpak Nariana, who practices in Florida. 90-degree curves, small accesses. This is an interesting case because you have to ask yourself, what file system are you going to use here? And it is an ideal case for the V-taper instruments where you've got a long, relatively parallel, small diameter upper profile to the file. Another case from Michael Trudeau, amalgam buildup with a composite close for aesthetics. Scott Weed, same situation, and amalgam core under a composite occlusal. This case to me is the poster child for these kinds of access preps, and it's got small upper diameters to the canals. They're big enough to get obturation, they're big enough to get irrigation, but they're respectful of the amount of dentin that's there. They don't transport the canals. They've got a small conservative opening of the pulp chamber, and it's got a flare in the occlusal for visibility and to allow for straight line access. So you get this kind of typical hourglass shape to the access. Does conservation make a difference? And I think it does. There's a recent article that was published by Christian, and he tried to answer the question, do these conservative shapes result in stronger teeth? And in fact, testing conservative shapes versus more typical access shapes and control of no shapes at all, the conservative shapes were almost as strong as the control cases with no access in them in the molars. Wasn't quite as clear in the anteriors, but in the molars they were stronger. So the conclusion is that conservation of the coronal dentin in fact does increase the resistance to fracture in molars and premolars. So to close, this is what I see the new look of endodontics being. And you have a case that is done with smaller instruments, conservation of the dentin, and some hand instruments were needed for the middle mesial. This is the new look of endodontics. And with that, we will take some questions. The first question is, does the preservation of dentin in the cervical third of the tooth increase the viability of the tooth for long-term retention? We think it does because it helps reduce the amount of tooth fracture. That is one of the contributing reasons for tooth loss in endodontic procedures. It makes sense that conserving dentin increases the strength of the tooth, and a stronger tooth is going to last longer and be more resistant to fracture. What we really don't know is how much of a factor this is. We don't have good numbers on exactly why teeth are lost or what the factors are that contribute to that. But we do know that you cannot replace the strength of the dentin with restorative materials. So it's important to conserve dentin because that's where the heart of the strength of the tooth is. So simply adapting a newer file system and reducing the amount of dentin removed in the pulp chamber are two things that you can adopt to your practice tomorrow that should make a significant difference in the amount of teeth that are fractured post-endodontically. The next question is the legacy model of access and shaping still pertinent with the availability of modern technologies in materials and equipment? And the answer is simply no. This question actually strikes at the heart of the reason for these new access designs. And the features of the legacy models for our accesses were based on the need for straight line access, which was fundamentally dictated by the stiffness of the instruments, and these early instruments were stiff stainless steel hand files. Once nickel titanium rotary instruments came in, they ended up being too big a diameter and still had substantial stiffness, which made the straightening of the canals out still an objective that had to be met. The latest instruments, as reflected in the SSWhite designs, have a instrument profile which is smaller up at the upper end of the instrument, and that makes them substantially more flexible. Plus, they're made from heat-treated materials, which again dramatically increases their flexibility as well as their fatigue resistance. And because of that, you don't have to do the straightening of the canals like the legacy protocols talked about. That's allowed us to redesign access preps, which are much more conservative of dentin, and we think ultimately are going to result in stronger teeth. Good question, thank you. The next question is, how do you determine quality and success of a root canal procedure? To my mind, quality and success are actually two different but related things. Certainly the craftsmanship required to provide a quality result will eliminate many of the factors that traditionally contribute to failure. Things like missed canals, short fills, procedural errors like perforations. So to my mind, quality equates to a higher success rate because of that. The problem we have is we don't really have a good handle on the relative importance of what factors contribute to success. Plus, the whole issue of success, or what is success, is being reevaluated. We've used traditionally radiographic findings as a proxy for success, i.e. if you have a healed lesion on the radiograph, you have a success. If it doesn't heal, you have a failure. The problem we're getting into with the addition of cone beam CT imaging, we're finding teeth that have a demonstrable radiolucency over the tip of the apex that are otherwise completely comfortable, functional, and the patients are happy with them. So is that a success or a failure? It traditionally would have been a failure. We're reevaluating this, and I think we're heading toward a new definition of success. I expect the term to be dropped, and we'll end up substituting another better term for success and failure. The next question is related to irrigation and obturation, and it's asking the question if these shapes are too small to adequately irrigate and obturate. This is really a common concern that clinicians bring up the first time they see these shapes. And while it may be true if you try to apply your current protocols and instruments to these shapes, the solution is quite simple. You need to modify your protocols by going smaller with the instruments you're using. For instance, if you substitute a 31 gauge irrigation needle for a 30 gauge, you can get deep irrigation in these canal shapes. They now make smaller heat tips for doing warm vertical condensation. You can get carriers that will obturate these canal spaces, and injection techniques will work also. We will be producing another webinar in the near future that addresses this in more detail. The last question is, what are the most important factors in my decision to select an endodontic file? To me, the most important factor for a file system is that it creates a shape that's respectful of the natural anatomy of the tooth, which means you have to have a little bit of deep shape, enough for irrigation and control of the gutta percha, but you need to have a small enough upper shape that you're not removing excessive dentin. Secondarily, we need a system that's efficient, and we need a system that's strong so you don't have file breakage. The V-taper systems were specifically designed to do all of these things and handles this very beautifully.